¿Todos listos para la traducción? Espero que sí. Sigrid y Edgar ya agregaron en el chat.
Todo listo.
¿Todos listos? Sean todos muy bienvenidos. Let's explain to Dr. Michael what is AB Pro. AB Pro is a monthly holistic training because we think in multidisciplinary approach, including topics related to cochlear implants, but always including audiologists, otologists, and therapists. The AB Pro is a monthly webinar, and the focus is always on patient-centered care, based on cases and clinical evidence, like your presentation of today. For all attendees to interact and ask speaker questions, use the Q&A session. At the end of the presentation, Dr. Michael will be available to answer all questions. All attendees who wish to receive a certificate of participation in AB Pro, please request it in the link. I will post the link in the chat after. Today, we are happy to have a special guest here in Latin America. Let me introduce Michael Harris. He's a doctor of medicine, head and neck surgeon, otologist, neurotologist, and skull-base surgeon. He's associate professor at the Neurosurgery Medical College of Wisconsin in Milwaukee. He's also associate professor at the Department of Otolaryngology and Communication Science in the Division of Otology and Neuro-Otologic Skull-Base Surgery at the Medical College of Wisconsin in Milwaukee, too. The topic of today's AB Pro is AIM, Objectivity and Convenience, Intra and Post-Surgery. Thank you, Dr. Harris, for accepting our invitation and share your experience and research with AIM technology. Now the microphone is yours. I'll stop sharing my screen and you can share your screen now. I think you are mute. That's it.
Can you guys hear me?
Yes.
The title?
Yes.
Okay. All right, excellent.
Now it's perfect. Yeah, we are seeing your screen.
Okay, very good. Well, Mariella, thank you so much for that introduction. Thank you also to Sigrid and to all of AB for having me for the webinar tonight. It's a pleasure to join everyone. So as Mariella said, I'm Mike Harris. I'm a neurotologist and a cochlear implant surgeon here in Milwaukee, Wisconsin at the Medical College of Wisconsin. And as we were discussing offline before the webinar, where I live here, it's just now starting to become a little bit warmer. We're starting to think about planting our gardens. And I know for many of you, the season is changing in the opposite direction, so maybe getting a bit colder. But we're always thinking about cochlear implants. So the focus tonight, I'd like to share with you a bit about our experiences with the AIM system on intraoperative objectivity and convenience. And I'll be sharing some research and some practical tips and pearls for integrating specifically electrocochleography into one's surgical practice. So we'll share some details around a randomized clinical trial that we did using this highly novel tool in our cochlear implant patients. So my most notable disclosure, of course, is that I've served as a consultant for Advanced Bionics, and we have some grant support for this and related work as well. So the central premise that motivated this line of work is that as cochlear implant surgeons, as audiologists who work with patients with hearing loss receiving cochlear implants, and as investigators researching cochlear implants, we simply want more control over our outcomes. So when we have a patient like this, a common clinical scenario, a patient with an asymmetric sensory nerve hearing loss with very poor speech understanding on the right side, 36%. When we're confronted with a patient like this and meeting them and talking to their family, we know that they'll do better with a cochlear implant than they will with a conventional hearing aid. But we want more for them than that alone. We also want them to be able to benefit in all the domains that are shown to excel in the presence of a combined electroacoustic strategy. So combining low frequency acoustic input through a hearing aid-like component of a hybrid strategy and electrical input through the cochlear implant. So as many of us recognize, patients that can benefit from a combined EAS or electroacoustic strategy can do much better in speech understanding in complex or noisy listening environments. They can have superior music appreciation and the potential for some degree of constant sound awareness, even when their cochlear implant is not on and active. So some important safety and independence considerations. And most importantly, enhanced overall cochlear implant specific quality of life. Now, with those benefits in mind, the enhanced speech and noise, music appreciation, etc., we know that we need to achieve the objectives of hearing preservation through structure preservation. And working backward from that, we recognize what are some factors that might be in our control, that we might potentially be able to modify. So we know it's not all about trauma. There are certainly post-operative, post-surgical inflammatory changes that we combat using steroids, either topical or systemic, in the surgery and afterward, which is our practice. We also know the vital importance of achieving the correct scalar location of the electrode, which is why the convention has moved over time away from cochleostomy and towards round window or extended round window insertion. And we recognize that interaction of the cochlear implant electrode with the basilar membrane and with the cochlear hair cells can lead to structure damaging and hearing damaging trauma. And for this reason, all the practices that we call soft surgery have developed, including slowing down our insertion speeds, limiting drilling to the area around the round window in the case of round window insertion, use of lubrication. In MCW, we tend to use Helon to facilitate lubrication of the electrode. And then a lot of research and design on the part of our industry partners in designing minimally traumatic electrodes themselves. But in spite of all those best efforts, in spite of all the soft surgical technique, really in the end, we're only left to make an inference or a guess about what went on within the cochlea during insertion, which is the most crucial part of the surgery. We may get an X-ray or plain film at the time of the surgery to confirm the correct configuration, but it really doesn't tell us nearly enough about the fine interactions inside the cochlea. Instead, we make that inference about what happened a matter of weeks earlier from our subsequent pure tone and speech audiometry. That's how we appraise or grade our performance. And again, we know that trauma, and in particular scalar crossover, really matters and really impacts hearing outcomes, which is what matters the most to us and to our patients. And so we recognize that speech recognition scores decline as the percent of electrodes within the scala vestibuli, so outside the scala tympani, where the electrode belongs, and in the scala vestibuli, the more electrode in that location, the poorer speech recognition will be. Likewise, and more specifically, low frequency thresholds are elevated in the presence of scalar translocation. This is well demonstrated. And when we think about hearing preservation, the outcome here, we recognize that reports vary widely, and they're highly influenced by a number of factors. The type of electrode that's utilized, the degree of insertion, was it a partial insertion versus a complete full insertion? And then, of course, the follow-up periods. It matters a lot how far out patients are tracked as we determine outcomes. But it's a very fair statement to make that we collectively wish that we could do better and have more control over these outcomes. And we'd all like to see more than approximately 50% hearing preservation. So electrocochleography, or ECOG, has captivated our collective interest because it's been shown to be exquisitely sensitive to changes at the level of the cochlear micromechanics. Now, this is, as many of you recognize and have worked with ECOG in the past, this is an old technology, but it represents a new adaptation as the field, and in particular advanced bionics, has learned to make ECOG recordings from the vantage point of the cochlear implant electrode. And by way of that, reflecting the health of the cochlear hair cells and the cochlear nerve, and determining or detecting insertion trauma, again, to predict outcomes that we care about. So I'll share in more detail and a surgical video shortly, but the general approach is that in the process of a standard conventional cochlear implant surgery, at the point of surgery when we're about to advance the cochlear implant electrode, we can begin making electrophysiologic recordings of the hair cells, the outer hair cells, performance or health reflected by the cochlear microphonic. And these responses are generated in response to an acoustic stimulus that we're delivering into the external auditory canal using a speaker assembly that we insert at the beginning of the case. This stimulus can be adjusted in terms of its intensity or volume and the frequency. So typically at 500 hertz and about 110 decibels for most patients. So the knowledge gap that we sought to address in our study was to better understand the association between electrocochleography parameters relating to amplitude and how they relate to structure and hearing preservation. So specifically, what we were targeting is to understand how the number of drops in the signal and the magnitude of that drop and the insertion track patterns relate to hearing outcomes. So with that goal in mind, we designed a randomized prospective clinical trial to explore two hypotheses. The first is that we expected insertion track patterns and the amount of ECOG signal drop to have a positive predictive relationship with post-operative residual hearing. Regarding structure, we expected to see fewer translocations out of the scala tympani and into the scala vestibuli in patients that were randomized to having electrocochleography feedback on and available to their surgeon. So our sample of patients were patients that all met conventional cochlear implant criteria at their institutions. All patients had pure tone thresholds at or less than 80 dB at 500 hertz. We use predominantly slim J lateral wall arrays. A smaller proportion were pre-curved mid-scale arrays. And patients were randomized 50% to having the electrocochleography feedback in terms of an audible signal on and available to them to help supplement decision-making during electrode insertion. The other half of the sample was randomized to having that feedback off, and that was intended to represent a standard of care case. In all cases, however, the ECOG responses were measured. It was just a matter of whether or not the surgeon had that information available at the time of insertion. We had two primary outcomes. The first, hearing preservation. So looking at pure tone audiometry in comparison to their preoperative levels. And that was done at the time of activation and then later at 3 months. And activation in most of these cases was at 1 month. The second outcome relating to structure was scalar location. So we determined this by merging postoperative CT scans with preoperative scans. The scans were optimized for resolution of the electrode so that we could determine which scala they ended up residing in, scala tympani where it belongs, or did they translocate into the scala vestibuli. So for this study, our ECOG was collected using the AIM system. So AIM provides an opportunity to really take advantage of the unique recording capabilities of cochlear implants through back telemetry, which itself is not a new development. This technology has been around for quite some time in the cochlear implant world, but the most novel aspect of it is the ability to record electrocochleography, I would say. The AIM system itself is novel and convenient. It really brings all of the objective measures together in one place. So for those of you that have used this, you're familiar, but if you haven't, this is what's shown here is the tablet for the purposes of ECOG and these other objective measures. They're recorded at the level of the head coil that's put on typically in a sterile through a sterile bag at the time of the surgery. And so, as I'll share with you, this can be operated by an assistant that doesn't necessarily have to be an audiologist, but that's certainly the ideal case. And you can collect, in addition to ECOG, you can obtain thresholds, you can do your impedance check, which is routine for us in cochlear implant cases, as well as your electrical compound action potentials, ECAPs, or specifically for AB, the NRI measurements. You can also collect electrical subpolar reflex thresholds, ESRT, both in many, all of these, both in the operating room, which is my experience with AIM, and then in the clinic as well. So just some practical tips for efficient initial use of the AIM or at any time. It's important to keep in mind that you're delivering an acoustic stimulus into the EAC. So be sure to, with otoscopy or microotoscopy, make sure that the ear canal is in fact free of cerumen, so you have unobstructed delivery of the acoustic stimulus. And you have the option of putting in the speaker assembly using the AIM sterile insert, either in a sterile fashion or non-sterilely. It's our practice to initially put it in non-sterilely, and then our surgical team will prep around it and prep the tubing in as well. And it's important to make sure that attention is paid that no surgical prep gets in around the speaker or saturates the speaker, which will also affect delivery of the stimulus. So I like to apply a layer of bone wax around the speaker to help mitigate that problem. It's also important to make sure there's no kinking of the tubing, and that's actually quite hard to do. The kinking is not common, and it's hard to achieve because the tubing itself is quite rigid, which is a good thing, so that you don't have that issue at all. But important to keep in mind after you put the drapes down. And then communication, as always, is essential. So preparing your team ahead of time when you get close to the point of surgery, when measurements will be acquired. And then also, as we'll see in our video in a moment, it's important to communicate about the stage of insertion that you're at. Are you at the round window? Are you halfway through your insertion? Have you reached the second blue marker? And that's important because you can have your assistant operating the AIM system record at what stage of the insertion various ECOG features were noted. If there was a drop, when was that? That helps you refine your technique and understand how to use the system. As I mentioned, the AIM operator doesn't necessarily have to have special expertise, but it is beneficial to be familiar with the system ahead of time, so that they can navigate it efficiently. And it's also helpful for the assistant to communicate a bit about the appearance of the waveform, although it's not essential because there is an auditory feedback component. And the operating room really should be quiet as possible. It's our practice to usually have music on during a case, but then when we get close to this portion of the surgery, we'll turn that off so that we can hear the audible display from the AIM system well. So for the purposes of our clinical trial, there were a number of insertion parameters that were at the surgeon's discretion. That is, they could manipulate certain things in response to the feedback that they were getting through the ECOG. So they could adjust their insertion speed. They could slow down or speed up, but usually it's a matter of slowing down insertion. They could introduce a slight bit of angle adjustment, perhaps a slight bit of twist. And if they were responding to a dip in the signal, consider retracting slightly, a contact or two, to monitor for recovery. But for the purposes of our study that I'm sharing with you, we did not allow them to do a partial insertion. So in all cases, regardless of what the feedback ended up being, they were asked to complete to a full insertion, or as much as possible. So a number of scenarios might have been encountered. This is the guidance that we gave our team. The first being that the ECOG response steadily increases. And this is really what is, it's really gratifying to see. It's nice to hear those responses mount as the electrode advances. And in that case, if that's the response that the team is seeing and hearing, really no change in insertion parameters are necessary. However, there are many situations where the signal will dip or drop. And in those cases, we recommended at first stopping for a moment to allow for signal recovery. And if that was not observed, consider retracting slightly, again on the order of 1 or 2 contacts, and listening and looking for a change in the waveform. And then finally, if the surgeon happened to be seeing this drop right at the very beginning of insertion only, maybe even consider backing out and adjusting the vector of insertion. Now, finally, the scenario that may also arise is that the signal simply does not recover. And in that case, we again instructed the surgeons to proceed to a full insertion, or as close to a full insertion as the anatomy would permit. So what I'd like to share next is an intraoperative video, and the signal that you will be hearing is the audible correlate partnered with the waveform that's on the screen. You'll see 3 different panels, but the one to pay attention to is the largest of the 3. The AIM display in its most recent version is a little bit different, but the principle is the same. So here we are. This is our right ear. We're using a mid-scale electrode. And in the upper left is the surgical view. And on the screen is what the assistant will be seeing
What is it compared to the
as the insertion was beginning. Now, the surgeon only hears the audible response in these cases.
Close to 2 microns.
And we'll hear the pitch increase, which means that the cochlear microphonic reflecting outer hair cell function is growing.
Okay. Went to 2 microvolts. Okay.
Small dips, but generally trending in upward direction. We're advancing off of the stylet and passing off the stylet. You see that the signal starts to level out. So that is an example of the intraoperative experience. So our AIM operator here was marking in the point in insertion, beginning, mid-insertion, and then at the point of completion. So moving on to some of the data and our learnings from this randomized clinical trial. We were fortunate to have really robust multi-institutional and international collaboration in this study. There were 9 clinical sites, 9 high-volume cochlear implant centers. A total of 25 surgeons were part of this effort. We had 87 patients. As mentioned, about half of those were randomized to having the feedback on and available to the surgeon, and half off, representing standard of care. Most of these, 73 out of our 87, had lateral wall arrays, Slim J, and 14 had pre-curved mid-scalas. And in all cases, we collected ECOG for both groups. So the results that I'll share with you, if you'd like to learn more, if you want to read more about it, these are 2 publications from Otology and Neurotology in 2022, and then more recently last year. And I'm happy to provide anyone with further details on these offline. So the first bit of results I'd like to share relate to structure preservation with use of ECOG. And of our sample of 87 participants, 43 ultimately had postoperative CT scans that we could evaluate in a blinded fashion to judge the scalar location. So again, did the electrode remain in the scala tympani where it belonged, which is in the red panel on the bottom right? That is the scala tympani, or did it translocate? Did it poke through to the scala vestibuli where it does not belong? We did find 3 instances of translocation in our sample as a whole. All 3 of those were seen in the patients that were randomized to having ECOG off and not available to the surgeon. We didn't see any translocations in those that had ECOG on. As far as electrode type, 2 of those 3 were pre-curved mid-scalas, and 1 was the Slim J. Second set of results I'd like to share with you have to do directly with outcomes, with hearing preservation. And so what I'm sharing here is a scatter plot showing low frequency pure tone average change against the ECOG signal or cochlear microphonic drop. So what we're seeing here is the larger the drop in that signal, the more the hearing loss after surgery at activation. And for this particular finding, we did not see a difference across electrode types. The second set of hearing outcome-related results have to do with what we call insertion tract pattern. So in the video we just watched, we saw the signal essentially climb up from baseline and then eventually level out. We could hear, that was the appearance of the waveform. We could hear the signal increase in pitch. On the left here, these are 4 common types of patterns that we tend to see in these sorts of cases. So the panel on the upper left, type A, this is a situation where the signal simply climbs up, goes to a high point, and stays there. In our sample, that was present in about 21%. Type CC on the upper right, this describes a situation where the signal climbs up and reaches a high point, maybe dips down a bit, but stays at a level much higher than baseline. So this would describe the pattern that we just saw together in the video. For our sample as a whole in this study, 29% showed type CC pattern. Below that, type C is a situation where the signal climbs up to a high point, reaches that peak, and then drops off back to baseline. And this was seen in 32%. So we believe that the difference between type CC and type C is recovery or salvage of the signal, potentially through adjustments that the surgeon made during insertion. Finally, bottom left, this is the type D pattern. This is really no identifiable response above the noise floor. And that tends to be seen in patients with really the most, the poorest potential for hearing preservation, the least amount of residual low frequency hearing to begin with before surgery. So importantly, these insertion tract types have a relationship we've demonstrated with subsequent hearing preservation. So this is pure tone average change as across the different insertion tract types. So we can see that the type C pattern on the bottom right shows the largest amount of change from baseline. And importantly, more change from baseline than the type CC pattern that we believe represents a rescue of the signal. So then we looked at how do these insertion tract types that we know have a relationship to hearing preservation, how do they differ between the 2 arms of the study? Okay, so participants that were randomized to having the ECOG signal on and available to help guide the surgeon demonstrated significantly greater type CC, so rescue of the signal and better overall hearing preservation. On the other hand, we saw more of the type C associated with poor hearing preservation in those that were assigned to having electrocochleography off and not available. So the significance of this work, and I think of the AIM tool with regard to ECOG, is that through our study and many others before it, beginning with animal work and retrospective human studies, is that ECOG provides a novel, highly unique form of feedback from the cochlea and a highly needed form of feedback. What you see from the cochlea during surgery does reflect structure preservation. And by extension, that structure preservation has a relationship, a predictive relationship with hearing preservation. So that when we're in the clinic or in the audiology booth, when we're testing their hearing after surgery, hopefully we can bring about better outcomes. So a few considerations and pearls for integrating ECOG into your surgical practice if this is a new thing for you. First of all, while the use of the AIM doesn't necessarily add significant time to the overall experience, it does add some time initially. And you should be prepared to pad the time of your case time with a little bit of extra for setup and maybe for a little bit of light troubleshooting if something needs to be double checked. It's helpful if you have the option to have as consistent a team as possible so that your assistant and whomever is operating the AIM tablet knows how to navigate it smoothly and quickly. One of the biggest lessons, I think, for me and many others who use AIM and electrocochleography is the importance of slowing down electrode insertion. And that's key to be as responsive as possible to what you're hearing and what you're seeing in the feedback. And the decrease in the speed itself probably plays a critical role in minimizing trauma and inadvertent interactions with cochlear anatomy. It's helpful to develop an internal plan for you as a surgeon and you as an audiologist for who to use electrocochleography on. It was our practice initially to use this tool broadly for all our patients. But over time, we have come to apply it for ECOG, that is, for patients with some substantial low frequency hearing that we think a hearing preservation attempt is realistic and who might potentially benefit from an electroacoustic strategy. And then finally, important to track one's results, right? So through doing this, understand what you can do better and do differently and how to optimally use this tool. So most importantly, thank you all for your attention and joining us on this afternoon or evening. And I do want to thank all my co-authors and collaborators in the study that I presented today. And again, thank you to Advanced Bionics for allowing me to spend some time with you all